Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 444 of our pharmacotherapy series, which majors in prostate cancer. This video discusses the case of patient TES from part 443 of this pharmacotherapy series. My first question to you reads: now that TES has symptomatic bone metastases, what recommendations can be made to decrease the risk of skeletal-related events? Bone metastases occur in around 90% of men who develop metastatic prostate cancer and are a common complication in advanced disease. They may be asymptomatic but can frequently cause pain, decreased mobility, and diminished quality of life. These metastases can also cause skeletal-related events, which include pathologic fractures, need for radiation or surgery to the bone, and spinal cord compression. Prostate cancer bone metastases are primarily osteoblastic lesions, in which there is increased bone formation around tumor deposits. Additionally, there is increased osteoblastic bone resorption, or osteolysis. There are several therapies proven to have benefit in bone metastases by improving symptoms, preventing complications, or improving survival. We will briefly focus on bisphosphonates. The only bisphosphonate shown to be of benefit in patients with castration-resistant prostate cancer and bone metastases is zoledronic acid. In a Phase 3 study, zoledronic acid was shown to demonstrate a delay in skeletal-related events, including radiation to the bone, time to pathologic fracture, and bone pain. However, the study did not show an improvement in quality of life or a decrease in the development of new metastases. It is dosed at 4 mg intravenously every 3 to 4 weeks, but must be dose-reduced in renal dysfunction, and it is not recommended to use if renal clearance is less than 30 ml per minute. Patients should take calcium and vitamin D as necessary to prevent hypercalcemia. An uncommon but serious adverse effect of osteonecrosis of the jaw can occur with zoledronic acid use. And now let's consider receptor activator of nuclear factor kappa B ligand, abbreviated as RANKL inhibitors. Denosumab is a monoclonal antibody for the receptor activator of nuclear factor kappa B ligand, which is involved in osteoclast-mediated bone resorption and remodeling. When compared to zoledronic acid in castration-resistant prostate cancer with bone metastases, denosumab was more effective at preventing the skeletal-related events of pathologic fractures, need for radiation or surgery to bone metastases, or spinal cord compression. Denosumab also restored bone density. The serious adverse effect of concern associated with denosumab is the same as that with bisphosphonates, osteonecrosis of the jaw, and it also has a higher rate of hypercalcemia. Renal adjustment is not necessary for denosumab dosing. However, renal function should be monitored because of the increased risk of hypercalcemia in patients with renal clearance less than 30 ml per minute. For bone metastases occurring in patients with castration-resistant prostate cancer, denosumab is given as 120 mg subcutaneously every 4 weeks. Patients should take calcium and vitamin D as necessary to prevent hypercalcemia. Next we will switch gears to systemic radiotherapy. Systemic radiotherapy may be used, with radium-223 delaying time to first skeletal event in symptomatic bone metastases as discussed previously. It is the only bone-targeting agent with a survival benefit and can be a good choice for patients with extensive bone disease with otherwise minimal disease. Two beta-emitting radiotherapy agents that have been utilized are strontium-89 or samarium-153 in patients with painful bone metastases that is not responsive to palliative chemotherapy and pain medications. However, they have no survival benefit, and myelosuppression is a major concern that must be factored into the future plan if additional chemotherapy is to be used. External beam radiation therapy, although not systemic radiotherapy, is an option for one or a few symptomatic sites of bone metastases. It is most often used to provide symptomatic relief. And now we will look at hormonal agents. Abiraterone was shown, in the Phase 3 trial discussed earlier, to improve bone-related pain and delay the time to first skeletal-related event, that is 13.3 months versus 16.7 months. The PREVAIL study of enzalutamide prior to docetaxel therapy also showed an increase in time to first skeletal-related event. Patient TES should start taking calcium and vitamin D supplementation and can add weight-bearing exercises to his daily walking. In addition, his medical oncologist can recommend either zoledronic acid every 3 to 4 weeks or denosumab every 4 weeks. The next case reads, PRL is a 63-year-old male who has been on ADT therapy for just over a year and is experiencing hot flashes and mild depression. He also had a bone mineral density scan, indicating ADT-induced osteopenia. My first question to you reads, what can PRL's medical oncologist offer him to alleviate some of the side effects and complications he is experiencing from ADT treatment? We will now briefly consider vasomotor symptoms. Vasomotor symptoms will bother most men for the duration of their treatment with ADT. Hot flashes are characterized by an intense heat sensation, flushing and diaphoresis, involving the face and trunk and may also include anxiety and palpitations. These effects can vary in frequency, intensity, and duration. The mechanism may be because of a withdrawal of androgens, disrupting the equilibrium of the norepinephrine and serotonin neurotransmitters. Data has been taken from women as well as men in the efficacy of these agents because most therapies have seen similar efficacy in both men and women. These agents include, among others, estrogens, gabapentin, pregabalin, and venlafaxine. Gabapentin has been one of the most studied drugs for the treatment of hot flashes in men. Gabapentin at doses of up to 900 mg per day in men on ADT showed a significant reduction in hot flashes. Titration recommendations are to start at 300 mg daily and increase at increments of 300 mg to achieve the final dose. Pregabalin has shown some benefit in women at doses of 150 to 300 mg per day and has not been studied in men, but may be a reasonable option starting at doses of 75 mg twice daily. Serotonin and serotonin norepinephrine reuptake inhibitors have also shown benefit in men on ADT, although no placebo-controlled, randomized trials have been done to date. Venlafaxine at doses of 75 mg per day has been the most extensively studied from this drug class. Paroxetine has also been studied in men on ADT. The use of other agents in these classes have also been reported. Estrogens have also been used to treat hot flashes. Diethylstilbestrol and transdermal estrogen have resulted in good responses. Thrombotic events were not seen, but gynecomastia occurred in a number of men. Megestrol and medroxyprogesterone have also been studied, and one trial revealed a better response with medroxyprogesterone than with venlafaxine. However, there is concern that it might stimulate prostate cancer growth, similar to what is seen with an androgen receptor antagonist, and the agent should be stopped if cancer growth does occur. Alternative therapies have also been used to treat hot flashes. Acupuncture has shown some promise in small studies. Soy and herbal products have also been used. However, randomized controlled studies must be done to determine the true benefit of these therapies. Next we will discuss cardiovascular and metabolic adverse effects. There is concern of an association between ADT and risk of mortality from cardiovascular disease. However, this has not been consistently seen in clinical trials. Congestive heart failure and myocardial infarction have been identified as a risk highest in those who already have a risk of cardiovascular disease. A meta-analysis of studies with non-metastatic and non-castration-resistant prostate cancer did not find a significant difference in cardiovascular death in those men treated with ADT versus those who were not. The American Heart Association Advisory Panel concluded that links remain controversial and do not recommend periodic cardiac testing, but screening for cardiovascular risk factors should occur, and monitoring of blood pressure, lipid profiles, and serum glucose should be routine, especially in those men who receive more than 6 months of ADT. Androgen deprivation has been shown to increase the risk of obesity, decrease lean muscle mass, decrease insulin sensitivity, increase high-density lipoprotein levels, and increase subcutaneous fat accumulation. Screening for diabetes and hypercholesterolemia is necessary, particularly with long-term use of ADT. Regarding the sexual adverse effects, loss of libido and erectile dysfunction are expected adverse effects of ADT, occurring in up to 85% of men treated with ADT. The impact of ADT therapy may be delayed, with full effect occurring up to 2 years later. Recovery from erectile dysfunction will usually occur after cessation of therapy. However, for patients on long-term therapy, there should be open dialogue between the healthcare team and the patient regarding options available to help in mitigating these effects. Other factors that may be contributing to erectile dysfunction should also be considered, including a history of diabetes or cardiovascular disease, as well as whether the patient has had a previous prostatectomy. There is no consensus regarding the best therapy for this adverse effect. Phosphodiesterase inhibitors can be tried, as 44% of patients reported a benefit in one study. We will now briefly look at psychologic or cognitive adverse effects. Psychosocial adverse effects such as distress, depression, and cognitive impairment may occur. It has been estimated that up to 30% experience distress, 25% have increased anxiety, and almost 10% have a major depressive disorder. Low testosterone levels can affect mood in some men, causing depression and short temper. Routine assessment is crucial to identifying those patients experiencing these effects that can have a major impact on survivorship and quality of life, with referral for behavioral intervention considered, as necessary. Regarding bone health adverse effects, patients treated with ADT are more susceptible to decreased bone mineral density and bone fractures. In a study looking retrospectively at men diagnosed with prostate cancer from 1992 to 1997, those men who received ADT therapy were compared to those who did not and were found to have a higher incidence of fractures, that is 19.4% versus 12.6%, with a p-value less than 0.001. Androgen deprivation therapy increases bone turnover and decreases bone mineral density, with a 21% to 54% relative increase in fracture risk. Rapid loss of bone mineral density is seen within the first 6 to 12 months. The Prostate Cancer Survival Guidelines of the American Society of Clinical Oncologists, abbreviated as ASCO, suggest that all men who have received ADT should be assessed for the risk of fracture, using a baseline dual-energy X-ray absorptiometry, abbreviated as DEXA, scan and calculation of a FRAX, that is a fracture risk assessment, score. For those men who are determined to be high risk, there are a number of options. Alendronate 70 mg weekly, zoledronic acid 5 mg annually, or denosumab 60 mg every 6 months are available for use in this setting. Osteonecrosis of the jaw is considered to be the most serious adverse effect of the agents used to improve bone health. Patients are recommended to undergo a baseline dental evaluation prior to the start of a bisphosphonate or denosumab, with any invasive dental surgery done and completely healed before these agents are started. Good oral hygiene should also be stressed. Patient PRL's medical oncologist can offer patient PRL an antidepressant. Gabapentin, venlafaxine, estrogens, and acupuncture have been shown to have some benefit for vasomotor symptoms, such as hot flashes. If patient PRL is interested in being treated for both his depression and hot flashes, venlafaxine may be a good option, as it can treat both side effects at the appropriate dose. As for PRL's osteopenia, weight-bearing exercises, supplementation of vitamin D and calcium, and the addition of yearly zoledronic acid or bi-yearly denosumab can be given to prevent complications that can arise from bone loss. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 445.